We are back again for the online audience. We're going to continue with the morning sessions. There'll be 2 more lectures. The next one will be given by Dr. Vicente Torres from the Mayo Clinic, entitled Practical Guidelines for Treatment of V2 Antagonist in ADPKD. And I want to welcome Vicente, because and I understand that he will have a couple of questions at the end with the polling. Yeah. Vicente.
Yeah, thanks very much, York, for the invitation. It's always great to come to Toronto, enjoying your hospitality. So I'm supposed to kind of review the key results of clinical trials for tolvaptan in ADPKD, provide an update on the potential benefits and risks of this treatment, and then talk about who, why, and how to treat with tolvaptan, and if there is some time, maybe a little bit about high water intake. So the rationale for vasopressin V2 receptor antagonism in polycystic kidney disease is here. Some preliminary understanding of the function of the polycystins, of the importance of cyclic AMP in cystic disease, and physiology of vasopressin and the vasopressin V2 receptors in the normal kidney and in the polycystic kidneys. And all these led to preclinical trials of different vasopressin V2 receptor antagonists, 5 of them, which consistently show a protective effect in animal models in polycystic kidney disease. But these preclinical trials, although showed benefit, the benefit was not comparable to the benefit of genetic elimination of the vasopressin in the PCK rat, an animal model of polycystic kidney disease, where there was almost complete elimination of the disease and rescue of the disease by providing the vasopressin V2 receptor agonist. So the reason for that is the pharmacokinetics of the vaptans. Particularly with tolvaptan, you can see in the upper panel that after administering the drug in the mix with the food, where the animals eat the food in the early hours of the night, by the following morning the plasma levels are very low and almost completely gone by the afternoon. And this is much faster also if you give it by gavage. So, and you can see the effect of tolvaptan increasing the urine output in the lower output is almost completely gone in the afternoon. So that taught us that either to be effective with these animal models, you had to give a very high dose of tolvaptan, or a split dose, giving the food, the tolvaptan with the food in the evening, and then an additional dose by gavage about midday. So in doing that, you have a beneficial effect of tolvaptan, but you don't have, even given a relatively high dose, only mixed with the food. So from this, we learn that in the phase 2 models, phase 2 studies with tolvaptan in patients with polycystic kidney disease, that you had to reach a compromise, and you had to use a split dose of tolvaptan in order to have suppression of the effect of vasopressin in the kidney, as measured by keeping the urine hypotonic 24 hours a day. Even using the split dose and giving a total dose of 45 milligrams in the morning and 15 in the afternoon, or even increasing to 90 and 30, you have complete suppression of keeping the urine hypotonic for 24 hours, only about 75 to 80% of the time. And if you increase the dose further, you have a decrease in tolerability of the drug. And tolerability was defined as the capacity of a patient saying that I would be capable to take this medication for the rest of my life. So you have to reach a compromise between efficacy and tolerability. The other thing that was learned in these preliminary studies is that tolvaptan reverses the effect of vasopressin on the tubuloglomerular feedback. So vasopressin, acting on the V2 receptor, reduces the concentration of sodium at the macula densa, which results in efferent vasodilatation and efferent vasoconstriction, which results in increasing GFR. And tolvaptan reverses that. So when you give tolvaptan, immediately you have a reduction in GFR. So tolvaptan has a hemodynamic effect. And that was also important in the developing of the protocols for the phase 3 clinical trials. Now, the approval of tolvaptan was based on two large phase 3 clinical trials, TEMPO 3-4 and REPRISE. TEMPO 3-4 was a parallel arm study, and REPRISE was a randomized withdrawal type of a study. TEMPO 3-4 was early disease, and REPRISE was in advanced disease. And both the studies, a reason for the success of both the studies is that both the studies use prognostic enrichment to select the patient for the study. The prognostic enrichment in TEMPO was in order to be in TEMPO, you had to have a total kidney volume above 750 mLs, despite being of a relatively younger age and still having normal creatinine clearance. So it was a way to ensure that the patients that were going to be enrolled, they would be enriched with patients that were actively progressing with the disease. In REPRISE, the prognostic enrichment was assured by requiring a lower GFR in the patient that had an older age, and in the patient that had an older age between the ages of 55 to 65 to require a historical reduction in the rate in the GFR of 2 mLs per year. In addition to these two large randomized clinical trials, both of them were followed by open label extensions. So in TEMPO 3-4, what was observed, the primary endpoint was the change in total kidney volume. And the change in total kidney volume went down from 5.5% in placebo to 2.8% with tolvaptan. However, most of this reduction in the total kidney volume was obtained during the first year. So actually, during the first year, there was an actual decline in total kidney volume. And after the first year, there was increase, and the kidney volume started to going up, although not at the same rate as it was going up in the placebo. The secondary endpoint was the change in kidney function, which was measured by the reciprocal of serum creatinine. And the rate of decline of reciprocal of serum creatinine went down from 3.8 to 2.6. But if you look at the analysis by different subgroups, you can see that this effect was more obvious in the patients that were over 35 years of age with hypertension, had a GFR already below 80 mLs per minute, and had a kidney volume above 1,500 mLs per minute. What that means is that the TEMPO 3-4, the best result was observed in the patient that already had more advanced and more progressive kidney disease, or polycystic kidney disease. Was observed overall in all the patients, but in this subset of patients was more obvious, which makes a lot of sense, and I will go back to that later. Another secondary endpoint was an overall composite to different progression events, and this was led mostly by kidney pain and events of kidney function decline. Now, the effect of tolvaptan on events of kidney function decline started to be observed after the first year of the study, whereas the effect of kidney pain was started to be observed immediately after starting the study. And this reduction of kidney pain was related mostly to less stones, less episodes of gross hematuria, and urinary tract infections. Now, that's in TEMPO 3-4. You can see that immediately after starting the administration of tolvaptan in the treated groups, there was an acute hemodynamic effect. And during the 3 years of the study, the rate of decline of kidney function in the tolvaptan-treated patients in blue was less than in the placebo-treated patients. So after washout, when the tolvaptan was withdrawn, the patients taking tolvaptan, the GFR increased. So during the open label study, all the patients started taking tolvaptan, or were taking tolvaptan, and during the open label study, there was no difference between the two groups. So what this showed is that during the 2 years of the open label study, the benefit that was observed during the double-blinded period was preserved during the following 2 years. During the Tempo 3-4 study, about 23% of the patients treated with tolvaptan withdrew from the study, most of them because of aquaresis and polyuria, and not being able to tolerate that. So because of that, the Food and Drug Administration requested that for the reprise study in patients with more advanced disease, that a different protocol was used a randomized withdrawal design. So what that means is that all the patients entering the study were started taking tolvaptan, and you can see the acute hemodynamic effect of the tolvaptan. Then the patients that were able to tolerate the tolvaptan were randomized. The patients that were not able to tolerate the tolvaptan were not enlisted into the study. So the patients were randomized to withdrawal of the drug or to continuation of tolvaptan. The patients that continued tolvaptan, the GFR remained and went down. The patient that the drug was withdrawn, that was the placebo-treated patients, the GFR went up and then went down. And the rate of decline of GFR was faster in the placebo-treated patients than in the tolvaptan-treated patients. So after washout, the patient treated with tolvaptan had an increase in GFR that was better than the placebo. So overall, the patients on placebo had a drop of GFR of a decline in GFR of 3.61, whereas the tolvaptan-treated patient was only 2.34. On the sub-analysis, what it was seen is that the only patients that didn't benefit from the tolvaptan were the patients between ages 55 and 65. So the older patients had no benefit from tolvaptan in the reprise study. So despite that, there was a study that has been done more, that was done later on, which a retrospective analysis of tolvaptan-treated individuals from multiple tolvaptan clinical trials that were age, sex, and eGFR matched to controls from the overture and the whole PKD study. And in this retrospective analysis that included patients between ages 55 to 65, tolvaptan was also effective. However, that was not a randomized study, so there were possible multiple biases here. So this has to be taken with a grain of salt. Now, the open label study, open label extension study of reprise included the patients that at the end of reprise had a GFR between 15 and 29 mL per minute, which included patients that had been treated with tolvaptan and patients that had been treated with placebo. So these patients were matched and were compared. So this is during the reprise trial. The patients that had a GFR between 15 and 24 during the reprise trial, where the GFR was dropping at a rate of 3.8 mL per minute, whereas the patients that treated with placebo was dropping at 5.4 mL per minute. During the open label study, both groups of patients were treated with tolvaptan, and the rate of decline then became the same. So the patients that were declining faster treated with placebo during reprise, during the open label study, they decline at a slower rate of 3.4. And that's for the group of patients between, with a GFR between 15 and 24. And the same was seen for the group of patients between a GFR of 25 to 29. So during the reprise study, the patients taking placebo were dropping 4.9 mLs per year, patients taking tolvaptan 3.2, but after going on tolvaptan during the open label extension, the rate of GFR of decline was the same. Again, indicating that tolvaptan, even at very advanced stages of the disease, has a beneficial effect. And what this provides is support to, or indicates that there is no need to stop the administration of tolvaptan in patients taken with tolvaptan when the GFR drops below 25 mLs per minute. This is another retrospective pool analysis of patients treated with tolvaptan, where the tolvaptan was discontinued for various reasons, and that have been off treatment with tolvaptan for at least 180 days. And what this shows is that after discontinuation of tolvaptan, there was an acceleration in the rate of decline in GFR and in the rate of increase in total kidney volume. Again, that's a retrospective pooled analysis, so maybe biases involved in that, but that also suggests that tolvaptan has a beneficial effect. Then there has been a randomized clinical trial of tolvaptan in a pediatric population, so children or young adults or young or adolescents between ages of 4 and 17 years of age. And this is a relatively small study. And the study showed that the drug was successful in doing what it's supposed to do, inducing polyuria and reducing the urine osmolality. And the effects on total kidney volume and eGFR were in the right direction, but did not reach a statistical significance, although there may be quite a few reasons for that, including the small number of patients and the patients having still good GFR. So in the summary, TEMPO 3-4 and REPRISE get positive results, and the open label studies show persistence of the positive beneficial effect, and also significant effect in very advanced stages of the disease. One thing that is important in TEMPO 3-4, there was a benefit of 1 ml per year. In REPRISE, there was a benefit of tolvaptan of 1.3 mLs per year. So say 1 ml per year, 1.3 mLs per year is not a lot. And it's true, it's not a lot, but it's of the same scale of the benefit that has been shown with converting enzyme inhibitors in diabetes mellitus, in diabetic nephropathy, for example. But also one point is important to know is that once you do the analysis of tolvaptan and REPRISE by in the CKD stage of the disease, you can see that in CKD1 patient, there was no benefit. There was no benefit because the GFR was still normal. It was not going down. So it's difficult to see a benefit when the GFR is still normal. And then the other thing that you can see in REPRISE, in the patients that had very advanced disease, CKD T3B and 3D4, the benefit was a little bit less than 1 ml, was only about 0.8 mLs per minute per year. But if you look at the patient with the stage CKD 3A, both in the TEMPO 3-4 and in the REPRISE study, that's where the benefit is the most, because are the patients where the GFR is already declining, but still the disease is not very advanced. So that kind of gives you an idea of when the tolvaptan is the most efficient in these patients. So in terms of update, possible benefits, and that's the thing. We have benefits, we have risks, and we have a lot of uncertainties. And that's from the KDIGO guidelines. So starting with the benefits and the uncertainties, of course, the benefit of tolvaptan is to delay end-stage kidney failure. And based on the studies extrapolations from TEMPO 3-4 and REPRISE, the benefit is greater when you start the disease, the treatment earlier in the disease. So if you start the treatment when the GFR is still normal, you may project that you can have a benefit of about 7 mLs in terms of extension of the life of the kidneys. Now, this has not been demonstrated, is not going to be demonstrated for quite a while, if it ever. And what is available is what has happened in the studies that we have that have had a more prolonged follow-up. So at Mayo, we did a study in patients that had been on tolvaptan up to 11 years. And we matched these patients to patients from the CRISP and the HOLT studies. And in this matching, we saw a benefit of about 1.3 mLs per year. The study pulled data from Otsuka, and a study from Japan also showed the benefit. And a recent abstract from the group in Groningen from Ron Gansevoort also show a benefit in slowing the decline of GFR, although they did not demonstrate a significant benefit in the change in total kidney volume. So overall, this suggests that this benefit of tolvaptan is going to be sustained over time, and it will really delay the onset of kidney failure. Now, the most optimistic view comes from this study, a small study from Northeast England, from the National Registry of Rare Kidney Diseases, where they studied 21 patients of age 18 to 65 with baseline GFR of 30 to 89 mLs and a rate of historical decline of GFR of 2.5 mLs per year following the ERA definition of rapidly progressive kidney disease. But these patients were the patients that were able to tolerate tolvaptan for at least 12 months. So patients that were not able to tolerate tolvaptan for at least 12 months were not part of this study. But in this study, for the patients that were able to tolerate tolvaptan for at least 12 months, what they were able to show compared to the eGFR slope before going to the study was a reduction in the rate of decline in GFR from 6.0 to 2.47 mLs per minute. And they estimated that this could delay the onset of kidney failure by 15.3 years as compared to 6.9 years as compared to 15.3 years. Interestingly, they were, in this study, all the patients but 2 were able to tolerate the maximum dose of tolvaptan of 90 milligrams in the morning and 30 milligrams in the afternoon. And they claim in the article that that was due to tolvaptan clinic effect, that these were patients that were very carefully selected and very carefully followed and very carefully educated on tolvaptan. Now, in terms of other possible benefits of tolvaptan, well, the post-hoc analysis of TEMPO-3-4 showed that there was a reduction in blood pressure, a reduction in urine albumin excretion, and a reduction in MCP1 excretion that occurred after the first year of treatment. There have been other analyses, post-hoc analysis showing that tolvaptan reduces the lithogenic risk and reducing the supersaturation for calcium oxalate, brucite, and uric acid stones, increasing citrate, and reducing net acid excretion. Also, it has been shown in a study that tolvaptan increases bone mineral density at the hip and the cortical bone, although not at the spine with the trabecular bone, and that increases plasma magnesium, bicarbonate, and urine pH, and lowers parathyroid hormone, and as a result of that, 1,25-hydroxyvitamin D. So this suggests a positive result on bone metabolism with tolvaptan. However, whether that is of any clinical significance is questionable, because although a distinct bone phenotype has been described in animals and in humans with polycystic kidney disease, the 2 studies show that the risk of fracture in kidney failure patients with or without ADPKD is similar, and also that the bone mineral density in patients with ADPKD after transplantation, that was a study at Mayo, is higher in size where cortical bone is predominant, femoral neck, but not trabecular bone. So even if there is a positive result, a positive effect on bone metabolism, whether these are clinically significant or not, is questionable. And then there is a recent study that has shown that tolvaptan also reduces the QT interval and heart rate in the ADPKD patients. And whether that is of any clinical benefit or not, that's open to question. So these are in terms of benefits, and now in terms of risks. Of course, the main risk is, the most common risk is aquaresis and polyuria. And this is a study from, that's a study from Toronto, I believe, that of all the patients, so from here, that were all the patients that were considered to be high risk for progression, only 96 of the patients, so about 1/3 of the patients are taking tolvaptan, 2/3 are not. And the reason for these 2/3 not taking tolvaptan is mostly polyuria. And so the polyuria is a major factor in the acceptance of tolvaptan by patients or the willingness to be on tolvaptan. And also, this other study from Australia showed that the patients who started tolvaptan, about 1/3 of them, or slightly more, stopped tolvaptan, and the main reason for stopping tolvaptan is polyuria. And the patients who were young patients in the green are the patients that are most likely to stop tolvaptan because of the lifestyle. And again, here shows that the main reason for this drop in most of the patients stop tolvaptan in the first year, and the reason for the drop is mostly polyuria, second being abnormalities in liver function tests. So polyuria is important, so what can be done to reduce polyuria? This is a recent study from the group in Groningen showing that in reducing the salt intake from about 10 grams, that was what the patients were taking, to about 5.5 grams, that reduces the polyuria by 11%, together with low protein, and low salt alone reduces the polyuria by about 8%. So kind of cutting down the osmolar load of these patients is very important, reducing protein and reducing salt. Now, patients with nephrogenic DI can be treated with hydrochlorothiazide to reduce the urine output. So based on that, the group in Groningen also did a study using hydrochlorothiazide, but also metformin, and they were able to reduce polyuria from 6.9 liters to 5.1 with hydrochlorothiazide, and from 6.9 liters to 5.4 with metformin. GFR remained stable with metformin, but dropped a little bit with hydrochlorothiazide. So that raises the question of whether hydrochlorothiazide may reduce polyuria, but may be detrimental to GFR. When they did further studies in an animal model, they found that actually the combination with hydrochlorothiazide not only reduces polyuria, but also may have a possible beneficial effect in kidney volume. So that's kind of raises the question, hydrochlorothiazide in combination with tolvaptan may be detrimental if it eliminates the benefit, but on the other hand, may enhance the benefit. They don't know that. Surprisingly, on the patients on tolvaptan, the administration of hydrochlorothiazide reduced the copeptin level, so that could be good. We don't know. There is a study ongoing in the Netherlands now comparing hydrochlorothiazide and tolvaptan with tolvaptan with placebo. And so that will be a very interesting study. Now, that thiazide reduced polyuria has been shown in other studies, one from Japan, a recent study that was reported at the ASN. So that thiazide reduced polyuria is pretty well established, whether it can be done without compromising the beneficial effect of tolvaptan that requires, still need to be shown. Another drug that reduces polyuria is octreotide, and that's work from the group of Remusi in Italy. And that's particularly interesting because there is the possibility that octreotide and tolvaptan could have additive effects, additive beneficial effects, and have the extra benefit of octreotide reducing polyuria induced by tolvaptan. So that's very interesting, but that needs to be tested with a long clinical trial. So that's just speculation at the present time. And then, of course, the major effect, the major detrimental effect of tolvaptan is the risk of hepatotoxicity. So in kind of analysis, including over 2,300 patients that have been exposed to tolvaptan for over 18 months, there is approximately 5% of the patients have to discontinue tolvaptan because of increasing liver enzymes. During the TEMPO 3-4 and the open label extension, 3 patients met the highest criteria for for drug-induced liver injury, which is serious because 10% of the patients that meet drug criteria and the high criteria can end up developing liver failure. So because of that, there was a mitigation intervention that was introduced that the patient that mandated by the FDA. So the patients that are started on tolvaptan for ADPKD need to have monthly measurements of liver function tests for the first 18 months of treatment. And this has eliminated further cases of meeting Hy's law. And interestingly, the drug, the liver injury induced by tolvaptan has a clinical signature which is very the same. So it occurs during the first 18 months of treatment. After you stop the tolvaptan, still the liver functions can continue to deteriorate for a number of weeks. And it takes about 1 to 3 months to resolve completely after discontinuation. So the main culprit for the tolvaptan hepatotoxicity is thought to be an oxybutyric metabolite. And the 3 mechanisms of action that have been proposed is a strong inhibition of bile acid excretion, inhibition of the mitochondrial respiratory chain, and sensitization to tolvaptan. The sensitization to tolvaptan has received some support in a recent study showing that there are clones of T cells that are activated by the administration of the drug, and when these clones in vitro are exposed to tolvaptan, there is increased proliferation of these T cells, and this happens with tolvaptan. Patients that are sensitized to tolvaptan, this happens in vitro in the exposure to tolvaptan, but also to exposure to mosabaptan, which are the 2 vaptan that are more similar, but does not happen with lixivaptan and with conivaptan. But despite that, when in the lixivaptan trials that were started, there was 1 patient that developed elevation of liver enzymes, and actually the trial of lixivaptan was discontinued for that reason. So there are other side effects of tolvaptan. A study from Spain showed that about 25% of the patients taking tolvaptan have slight elevations of creatine kinase, and this may be by a kind of a effect of tolvaptan on the complex 1 of the respiratory chain, but it does not appear to be clinical significant. There were only 6 patients that had to discontinue the medication, 1 because had persistent progressive elevation, and 2 because of myalgia, and 3 because have concomitant elevations of liver enzymes. But the other patients were able to continue, and the creatine kinase normalized despite continuation. And then thromboembolic events have been reported to the Food and Drug Administration, but whether these thromboembolic events are more than one would expect by chance association alone is unclear, because there are a number of factors that predispose patients with ADPKD to thromboembolic events, one being chronic kidney disease, and the other one erythrocytosis, IVC compression in some cases, and hepatic venous outflow obstruction in some cases. So who, why, and how to treat with tolvaptan? Well, who is a patient that are rapidly progressive disease, as has been recommended by different regulatory agencies. The problem is how you define rapidly progressive disease. And the best way to define rapidly progressive disease is based on the Mayo image class, which integrates total kidney volume and the age of the patient, as well as eGFR, because once you have a decline in GFR, you don't need the total kidney volume. And there are other algorithms that have been proposed that are also of value. That the KDIGO recommendation that is coming up in 2025 is that to initiate treatment with tolvaptan in adults with ADPKD with a GFR over 25 mL who are at risk for rapidly progressive of the disease. Of course, that's a decision that has to be depends on the kind of communication between physician and patient. Now, the risk for rapid disease progression is indicated by the Mayo image class 1C, 2-1E, or by a historical rate in eGFR decline of over 3 mL per minute per year. And the recommendation is to use MRI or CT scan for the Mayo image class, but if not available, use ultrasound and ellipsoid equation are also acceptable. And again, there should be a shared and individualized decision-making, especially in patients that are over 55 years of age, where there is the evidence of benefit is the weakest. There are absolute contraindications and relative contraindications. Of course, the absolute contraindications are pretty obvious: pregnancy, breastfeeding, risk of volume depletion, inability to respond or to perceive thirst, uncontrolled baseline hypernatremia, urinary tract obstruction, strong cytochrome P453A inhibitors, and significant liver disease other than polycystic liver disease, and as well as some relative contraindications. And in terms of how to treat patients with tolvaptan, an article that is, I think, very useful is this article by Fouad Chebib of a practical guideline for treatment of rapidly progressive disease with tolvaptan. And that takes into consideration many factors. One, patients that are not candidates for tolvaptan because they are not rapidly progressive, as indicated earlier by Ron. They should have a basic optimized ADPKD management, as he discussed. The patient should be educated, because the reason why you have high discontinuation sometimes due to polyuria is because patients have not been properly educated, so they should be aware that the polyuria is particularly bad the first few weeks after you start treatment, and then it settles down and becomes more tolerable. They should be aware that we expect a reversible reduction in GFR immediately, of about 5 to 10% after starting the medication. And there are other possible side effects, like a slight increase in uric acid, and that antihypertensive medication may need to be adjusted. Good practice is not to start on a work day, to start the tolvaptan on a rest day, that to instruct the patient that they have to drink enough water to prevent thirst, to avoid fluids with high sugar or fat. And they should be aware that should drink at least 2 to 3 liters during the day, and 1 to 2 cups at bedtime, and when waking up to go to the bathroom also a little bit more during the night. And that they have to follow dietary changes to reduce osmolar loads, which reduces the polyuria, and monitor the body weight, and to halt the medication in conditions interfering with hydration or leading to dehydration, and to ensure water quality. Now, patients, the recommendation is to start 45 milligrams in the morning, 15 milligrams in the afternoon, But patients that are not able to tolerate that, they can go down to 30-15 or 15-15 because patients respond to tolvaptan in very, very different ways. Some patients are able to tolerate 90-30 without problems, and some patients have massive polyuria with just 15-15 because every patient is different. And the patients who should follow the monitoring of liver function tests 2 weeks after starting treatment, and monthly after the first 18 months and every 3 months thereafter. And it is recommended to measure plasma sodium at the same time to be able to say whether the patients are not drinking enough or they are drinking too much. It's quite interesting sometimes that some of these patients can develop hyponatremia because they drink even more than they can pee out. And and also we measure creatinine just to be sure that the creatinine does not increase more than the expected amount that you would predict when you start medication. And then in terms of monitoring the liver function test, if there is an elevation in ALTs, then the medication should be stopped immediately, and patient should be followed. And if the increase in the liver enzymes increase to more than 3 times the upper limit of normal, the medication should be stopped permanently. If it returns to normal, then re-challenging with a lower dose of medication, but intensive follow-up can be done. And then in terms of monitoring treatment efficacy, you expect the first year to see a reduction in total kidney volume, and then you can measure kidney volume every few years, but that's difficult to kind of know what happened individually in one patient because you don't know what would have happened not taking tolvaptan. So that's a problem. And then just a few words about high water intake. Ron already provided the results of the Australian trial, the Prevent PKD trial. However, important to note again that only 50% of the patients adhered to the treatment that they were supposed to have, and that the reduction in urine volume between the treated patient and the control patient was only about 400 mL, very small difference in fluid intake. And there is this interesting post-hoc analysis, actually that study done by Ron's group, that showed that and they started the correlation, they studied the correlation between the change in urine osmolality at 3 weeks after starting tolvaptan in the Tempo 3-4 trial, with the change in total kidney volume at 1 year after starting tolvaptan. The interesting thing is that there was a correlation between the decrease in urine osmolality at 3 weeks and the increase in kidney volume at 1 month. But this was observed also in the control group. And the reason why it was observed in the control group is because patients on the control group started drinking more water because they were instructed on drinking more water. So the fact that the patients that had more reduction in urine osmolality after the first 3 weeks had the least increase in total kidney volume at the end of 1 year suggests that the increase in water intake alone may have a beneficial effect in the progression of polycystic kidney disease that could be detected in this study, but not in the study by the Australian group. So I think that's basically it, and I have 2 questions. We have time for that, or yes. Yeah. So the first question is, which of the following is the most helpful for the nephrologist in deciding whether to recommend treatment with tolvaptan in a patient with ADPKD? Reported kidney length by ultrasound, reported measurement of total kidney volume, direct examination of an abdominal MRI by the nephrologist, results of genetic testing, and estimated GFR. And that's a tricky question. That's a very tricky question, because no one got it right. The most beneficial is direct examination of the MRI by the nephrologist, because the first thing you have to do is to be sure that the MRI shows typical ADPKD. If it does not show typical ADPKD, everything else is useless. So, and nothing here tells you that the patient has typical ADPKD. So the nephrologist should always watch and look at the MRI. That's the message of the question. And
Next
second question is, in the countries where a vasopressin V2 receptor antagonist has been approved for the treatment of ADPKD, which of the following patients is likely to derive the most benefit from treatment with this drug? 55-year-old man with a total kidney volume, height-adjusted total kidney volume of 300 mL per meter. A 35-year-old woman with a PKD2 mutation and a serum creatinine of 0.9 milligrams per deciliter. A 30-year-old man with a height-adjusted total kidney volume of 1,200 mL and a serum creatinine of 0.9 milligrams per deciliter. A 70-year-old man with a serum creatinine of 2.6 milligrams per deciliter. Or a 40-year-old woman with a total kidney volume of 1,800 mL and 3 Cs measuring 520, 464, and 285 ml. Okay, this one, almost everybody got it right. So
Thank you very much, Vicente, for a very interesting and talk, and also covering many fine points of tolvaptan treatment. Thank you very much.